Hi, my name is Rui Pereira da Costa, organizer of this International Endomasters 2015, and it is my great pleasure and honor to announce the opening of the first World Online Congress of Endodontics. As you probably know, the idea of creating this Congress came from my passion for sharing, learning, and teaching endodontics. Sum that to my passion for innovation and online learning, and you have the formula to this groundbreaking event. I must confess, though, that even being a dreamer, never in my wildest dreams I thought we could reach these numbers. More than 8,000 participants from 109 countries. Amazing, isn't it? Well, this makes me truly happy, for my vision was to take the state-of-the-art in clinical and scientific endodontics as far as possible, helped by this wonderful thing called the Internet. We are bringing this unique event everywhere, without geographical, physical, political or time boundaries. No need to travel, no need to find where to stay, and free. All you have to do is to be here on time and enjoy each and every lecture. And we couldn't have a better start. My great friend Jan Berghmans from Belgium will open this Endomasters with a wonderful lecture about endodontic diagnosis. I've known Jan for a number of years now, and I can tell you he is a great clinician with a clinical sense that makes him someone whose opinion I trust very much. Jan is a founder member and the actual president of the oldest endodontic society of Belgium, the Flemish Society of Endodontology, and in 2013 he has been appointed chair of the European Society of Endodontology Corporate and Public Relations Committee. Before I leave you with Jan Berghmans and his wonderful presentation, let me just invite you to use the comments area to send any questions or comments you have. They will be redirected to Jan and he will answer according to his availability. Hope you enjoy, and once again, welcome to the International Endomasters 2015. See you soon.
Hello, my name is Jan Berghmans from Brussels. It's an honor to be here, to be part of this fantastic event, which is International Endomasters 2015. My topic is about basic diagnostics. It's not a very fancy topic. In my opinion, quality healthcare is about two consecutive different processes, and the first and the most important is about doing the right things, and only afterwards we try to do the things right. So first is doing the right things, and second is doing the things right. And very often in very technique sensitive disciplines of healthcare, people tend to jump immediately, or at least very fast, to the second part of the healthcare process, which often gives us problems.
So I just wanted a checkup, really, because I'm going abroad. Right. General checkup is nothing to it. Anything else? Check my blood pressure. Yep, good. Okay. Let's get started. Stethoscope. Just there. Gotcha. I'm just going to be popping. I'm going to be popping it onto your chest. Just breathe in. No, just breathe less. Yeah, that's super. Good. Right. Could you just have this? Great. Good. On the couch, please. Okay, yeah, that's fine. Let's put them on the couch. I'm just going to be touching your tummy. Touch your tummy. Well, should I just take my jeans off? No, don't do that. Don't. Just get off. Have you felt any little lumps on your breasts lately? No. Unless my boyfriend's bollocks count now. Anything at all? No, just if you want to just check that everything's okay. That's fine. Good. Good. All in order. You've got a fibroid. Sorry? You've got a nasty fibroid. What does that mean? It's just a small operation. It's just a little scrape. It'll evacuate it very quickly. All right. Should we do that now? No, not now. Not now. No. Thank you.
Okay, let's get serious. Let's talk about basic diagnostics in dentistry and basically in endodontics. When I look at an image like this one, when we look at an image like this one, I would like everybody to check and observe simply everything. From left to right and from the top to the bottom, pay attention to any single detail that might be of any importance. And then more precisely in endodontics, I would like you to observe the complete periodontal ligament around any single of these teeth, and observe in detail what we might see over there. This is a nice example. It contains a lot of very important information, and we will come back to it later in the presentation. Same is true for this one. We look to these X-rays from left to right and bottom to top, and we concentrate on the PDL, and then we observe everything in an unbiased way, very open to anything that might appear. And the same is true for this one. So, like any single presentation, we should start by defining the subject. Diagnosis comes from the ancient Greek word dia, which means apart, and gignoschein, which means recognize, know, and we can define the diagnosis as the art or act of identifying a disease from its signs and symptoms. And it is what it is. Though we are living in an era of evidence-based dentistry, it's written there. It's also an art, and an art is more than only science. Differential diagnosis means that we try to distinguish diseases or conditions from other diseases or conditions presenting with similar symptoms. The International Association of the Study of Pain Taxonomy states that allodynia is pain due to a stimulus that does not normally provoke pain, and hyperalgesia is increased pain from a stimulus that normally provokes pain. So these words are important as when it comes to pulpal and periapical diagnosis. We have nice examples of terminal allodynia, for instance, in a way that the normal physiologic temperature being 37 is not hurting me normally, and from time to time we see patients in the reception area, waiting room, rinsing their mouth with ice water every 5 minutes to relieve the pain from pulpitis, because the normal physiological temperature, 37 degrees, is giving them pain. And examples of mechanical allodynia are the throbbing pulpal pain with every single heartbeat, while in normal condition the pulp will never feel the normal systolic blood pressure. Same is true. Same goes for the percussion. When we have an apical pathology, percussion is going to be positive, sensitive, painful, while in normal conditions with healthy pulps and healthy periapical tissue, it's not going to be painful when we bite on our teeth. Okay, so diagnostics can be very puzzling, very fascinating, and very difficult. Just let's start with a case. It's been a difficult case. It was a young lady. She was around, I think, 35 when she first visited the office, and she was complaining about having a lot of pain in the upper left area. And when we took the regular periapical x-rays, we could see, we could imagine, we could observe a lot of periapical infection areas around these roots. And to make sure, because these endos, the endodontic treatments that we had here were quite good looking. So if we have, well, these are not the most fancy endodontic obturations we might have, but compared to what we see on the average, this is quite fair. And when we are faced with quite good looking endodontic treatment and severe complaints and pain and symptoms, then it might be useful to take a cone beam CT, which is not something that we do on any single occasion, but we did it in this occasion. And we can see on all these slides, all these sections, that in fact, as a matter of, there are huge infections around the roots of the upper 6 and upper 7, 26 and 27. And this slide is showing exactly the same kind of phenomena. So we told the patient that the roots are, or that probably there would be a lot of fractures through the pulp chamber floor and maybe in the roots. Though we were quite convinced, she wanted me to open and explore these teeth, so that's what we did. And we could confirm the existence of these fractures inside the tooth. So each of these teeth, so they were pulled out in another session. And even after these extractions, she continued to complain about the same kind of pain, same symptoms. And then implants were planned, but since she was still having this pain, the implantologist asked me to do the root canal treatment of the bicuspid over, though it was quite good looking. We did it over, but still the same complaints remained after the treatment. So then she got the implants and the crowns on the implants, and now we are already 3 to 4 months later after the extractions, and the lady was still experiencing the same kind of pain, heavy pain. So she was really getting desperate, and she even believed that she would be allergic to implants, etc., etc. So she wanted us to pull the crowns and implants out, hoping that this would help her to get rid of the pain. This is not what we did. We refused because we did not understand the etiology of the pain. So she disappeared, and she came back, and she disappeared, and she continued to have pain. And probably around 1 year later, she called back to the office, and she said, well, you know, I still have this horrible pain from time to time, and it's getting even worse because I start to have pain while when I drink sweet things and when I go diving, etc., etc. And all of a sudden I started thinking about pulpitis somewhere in some of these teeth. And though we had been taking x-rays from the antagonists, and though I had been able already to see that the PDL around the first and the second molar was a bit thickened, and we see some dense bone formation around the mesial roots and the distal root of the 36. We never thought one of these teeth might be the reason of the problems. So in the end, it appeared to be a pulpitis of tooth 36. So around 1.5, 2 years later, after the first intake visit, we were able to figure out what was really bothering the lady. So we did an endodontic treatment of the first molar, and pain disappeared. So sometimes it's a quite difficult story, and I deeply regret that I was not able to help this lady faster and sooner, but that's the way it went. So this presentation is only a part of a bigger presentation. So in this presentation we will address the issue of the diagnostic terminology. We will talk a bit about pulpal pain mechanism. We will talk about a very important issue, which is the relation between clinical findings and histology. It is, as a matter of fact, when it comes to decision making, it is very important to know if the patient is suffering from reversible versus irreversible pulpitis. We will talk about the diagnostic methodology, the protocol. We will talk a bit about the performance and the statistics of diagnostic tests. And what's next? We will probably talk a bit about the test efficiency, the added value of some tests, and the patient's value regarding treatment. And then in the end we will talk a bit about what we can find on the internet, which might help us in the diagnostic process. But first, let's talk about terminology. There's been a call from the American Association of Endodontists in October 2008. There's been a meeting, and the purpose of the meeting was to establish a uniform diagnostic terminology. And in the end, the advice of the result of the meeting was that we should, before embarking on treatment, for any single case we treat, even if it's only a restoration, we should score the pulpal condition and we should score the apical condition from a clinical point of view. Always score both. As far as the pulpal condition is concerned, we have several possibilities. The first is the normal or healthy pulp. This is a clinical diagnostic category in which the pulp is symptom-free and the pulp will be responsive to the electric pulp tester. First remark, as it is stated, this is a clinical diagnostic category. It's been different in the past, and a lot of people have been trying to establish different types of pathology in relation to pulpal histology, and this is not working because we cannot know anything about the histology of the pulp based on what we see and based on what the patient is complaining about. So the classification must be based on clinical findings. So all these types of pulpal conditions and periapical conditions will be based on what we can see clinically during the diagnostic protocol. Another important point is that it's never going to be this way in 100% of the cases. So we all know that some teeth that might not respond to the classical pulp test, whether it be electrical or cold and warm pulp test, might be vital. So it's never going to be a universal truth. It's only going to be true in most of the cases. So when we test these normal pulps, these healthy pulps, we get most of the time a positive response that is only mild, and it subsides quite fast when the stimulus is removed. So this is a normal, healthy pulp. The second group is the group of the reversible pulpitis, and this is a category in which the pulp is a little bit inflamed, but inflammation should resolve when we remove the trigger of the inflammation, the reason of the inflammation. And we have different possibilities. The reason can be decay or cracks or recent restorative procedures, trauma or occlusal discrepancies. And all these factors may cause the pulp to become reversibly inflamed. The patient complaint is usually a sensitivity to cold or hot, and thermal testing will produce an exaggerated response, but once we remove the stimulus, the discomfort will disappear quite fast. Electric pulp tests results are responsive, positive. As far as the irreversible pulpitis is concerned, we have two subgroups. The first is the symptomatic, and the second one is the asymptomatic. The symptomatic irreversible pulpitis is about a pulp which is not an inflamed pulp, which is not capable of healing anymore. So most of the time, we will see that this is happening in 80% of the cases. Patients will complain, will talk about a history of spontaneous pain. So patients come in and they will talk about having had pain during the night on several occasions, and they will complain of an exaggerated response to cold or hot, and pain will linger after the stimulus is removed. It will continue to be painful. Electric pulp tests will usually be positive. Most of the time we will see that these teeth present with huge restorations, decay, or they may have had trauma or cracks, deep cracks, and radiographically the periodontal ligament space may appear to be normal, slightly widened, or demonstrate a distinct radiolucency. When I was a young dentist, for me, any single tooth that presented with an apical radiolucency had to be necrotic. So I was told that all these teeth could be treated without any anesthesia, which is a bad decision, and it's totally wrong, because whenever we have pulpitis, most of the time we see a widening of the PDL, whether it be in the furcational area or in the apical area or anywhere around the tooth root, for sure. One of the slides having been shown in the beginning is a nice illustration of symptomatic irreversible pulpitis. Patient was complaining about spontaneous pain, so there was a history of spontaneous pain. There was pain to hot and cold. We see a widening of the periodontal ligament space, and we even see dense bone formation around the first molar. So this was a nice example of symptomatic and irreversible pulpitis, and we did a root canal treatment. So a lot of pulps get inflamed without the patient ever noticing it, which might seem to be strange, because we always associate pulpitis with tremendous pain, very intense pain. But a lot of pulps get inflamed without any symptom, and a lot of these pulps will finally die without the patient having ever had any symptom or complaint. The pulp, once again, is incapable of healing, but we have no clinical symptoms. And two nice examples of this kind of process are the internal resorptions or the hypoplastic pulpitis. These are both nice examples of the asymptomatic irreversible pulpitis. So the next group of pulpal conditions is the pulp necrosis, and obviously it means that pulp tissue is dead, so we don't have any response anymore to cold or heat test. We have to be careful because some of these pulps might still react to heat stimuli, and we'll come back to that later. We don't have any response anymore to the electric pulp tests. A lot of these teeth will be asymptomatic unless inflammation has progressed to the periapical tissues. Then we have another group which is very easy to understand. It's the previously treated pulps. So the tooth has been endodontically treated before, and the canals are obturated with various materials other than intracanal medicaments. The tooth might still be symptomatic, might still respond to cold and heat test in case of missed canals, for instance. The tooth might become symptomatic also in cases of coronal microleakage, which will then lead to infection, finally. And the last group of the pulpal pathologies is the previously initiated therapy. It means that there has been some emergency intervention, a partial pulpectomy or something like that, and the treatment needs to be continued. Okay, now we jump to the apical pathology. First group is for sure the group of the normal apical tissue. So we see on the X-ray a normal PDL space, a uniform PDL space all around the root, and the tooth is asymptomatic, non-sensitive to percussion and palpation testing. Then we have the symptomatic apical periodontitis, and this means that there is by any means inflammation in the apical periodontium. It may be the result of occlusal trauma, it may be the result of pulpal pathology, and the patient will generally complain about discomfort upon biting or chewing. The tooth can present with any pulpal diagnosis. The hallmark is sensitivity to percussion. Palpation testing may or may not produce a sensitive response, and we can see a PDL space that might appear to be normal, slightly widened, or we might see distinct radiolucencies. The asymptomatic apical periodontitis is the next group, and it's characterized by inflammation and destruction of the apical tissues, and this process is a result of pathology in the pulp, but we don't have any clinical symptoms here. So we see apical bone resorption and an apical radiolucency on the radiograph, but we don't have any symptoms. Vitality and electric pulp tests are normally non-responsive, and percussion and palpation testing produce non-sensitive responses, since this is a group of asymptomatic apical periodontitis. So it's very often a finding on X-rays, but a patient doesn't complain about anything. Then we have the group with the acute apical abscess, which is characterized by a very rapid onset, tremendous spontaneous pain, tenderness of the tooth to pressure, even the slightest pressure, we might have pus formation and swelling of the associated tissues. Swelling will usually develop on the buccal or the lingual, or even in the face. Percussion testing produces a response that is usually exquisitely sensitive. This exaggerated response can help differentiate between symptomatic apical periodontitis and the early stages of acute apical abscess. Palpation test is always sensitive, and as bizarre as it might be, radiographically we may see a normal PDL. So the PDL space may be normal, slightly widened, or demonstrates with a distinct radiolucency. So most of the time when we are seeing these abscesses and we take X-rays, we expect to see huge areas, apical areas around these roots, but this doesn't need to be the case. On some occasions we see complete normal PDL around the tooth. This pathology is very often a result of a necrotic pulp or of an insufficient endodontic treatment with bacterial contamination and leakage. Chronic apical abscess is most of the time asymptomatic because there is a sinus tract, so there is drainage. The pressure cannot build up, and that is why there is little or no discomfort, and the patient is very often not aware of what's happening. All tests, electric pulp tests and trauma tests, will be non-responsive. Percussion and palpation testing usually produce non-sensitive responses, and radiographically we most of the time see an apical lesion which is associated with the involved tooth. This kind of pathology can also happen with teeth that have had insufficient endodontic treatment with bacterial contamination and leakage. Then we have the next group of apical pathologies, the group of the condensing osteitis. This is a kind of a pathology that I never linked to pulpal pathology when I was a young dentist. So condensing osteitis is to be considered as a LEO, as a lesion of endodontic origin, and it is very often the consequence or a sign of a low-grade, long-lasting, chronic inflammatory stimulus from the pulp. We very often see it under pulps that suffer from coronal cracks, for instance, or under teeth that have been extensively restored, etc. The patient may be asymptomatic or demonstrate a wide range of pulpal symptoms. Electric pulp test and tonal test may or may not be responsive. Percussion and palpation testing may or may not be sensitive. So we see bone formation, increased density of the bone around these roots. And we consider it as being a true lesion, and in most of the cases, 85% of these cases will disappear after endodontic treatment. So one of the slides we've been showing in the beginning is a nice example. The patient is complaining from now and then, let's say every 6 months, every year. She goes through a period of pain, which is very difficult to localize. It's somewhere in the bottom, sometimes in the upper, sometimes close to the ear, and the pain disappears, always disappears after a few days. And we see a slight widening of the PDL around the mesial root of the first molar, and we see very dense bone formation around the same root. And I expect that this is a sign of low-grade chronic irritation of the pulp. So we see that we can see that the restoration comes close to the mesial pulp horn, and I expect that we might need to do a root canal sooner or later on this tooth. Then we have another group which has nothing to do with endodontics or pulpal periapical pathology, which is a group of focal osteopetrosis, but we don't talk about it because it's not an endodontic problem. So if we summarize, we have on the one hand pulpal diagnostic possibilities, which is the normal pulp, the reversible pulpitis, the irreversible pulpitis, of which we can have two different, the symptomatic and the asymptomatic, with the pulp necrosis previously treated and previously initiated therapy. And as far as the periapical diagnosis is concerned, we have normal apical tissue, symptomatic apical periodontitis, asymptomatic apical periodontitis, acute apical abscess, chronic apical abscess, and condensing osteitis. So it would be nice if we would in our chart, in our files, always document and always use these terms. What makes it difficult is that at school we learn it starting from the pathology, and we learn all the symptoms that can come with the pathology. And in real life we have to think in the opposite direction. So we need to collect symptoms, and then we need to come to a conclusion as far as the pulp condition is concerned. And one of the most important conclusions or decisions we need to make is whether the pulp would be irreversibly damaged or only reversibly. And this is not always easy. So this is the overview of the apical groups. So why would it be so important that we agree on terminology? Well, first because we will have a better understanding of the disease process, because we will be able to link diagnostic terms to treatment options. Let's say vital therapy in case of reversible pulpitis, or partially damaged pulps, or endo versus endo. Will we prescribe antibiotics, etc., etc. It makes it easier to communicate with patients about their diseases. It facilitates communication with colleagues. We will all know what we talk about if we use the same terminology, and we will better understand the literature. So it seems to be important that we take care about using the same terms in our diagnostic processes. Okay, let's move to the second part of the second topic, which is about the pain mechanism in pulps. In this article published in the GOE in 2000, I was able to find a nice chart about different kind of innervations in the pulp and the characteristics of these two types of innervation. And this is quite important and clinically very relevant. So we have two kinds of fibers. We have the A fibers and we have the C fibers. And as far as conduction is concerned, the A fibers are conducting very fastly and the C fibers are very slow fibers. The pain, for the A fibers, it's a very sharp response, and the C fibers, it's a very dull response, deep dull response. The location of the A fibers is at the pulp-dentin junction, so very peripheral, and the C fibers are located more in the core of the pulp. The A fibers react to cold, and the C fibers, while the C fibers don't react to cold, they both react to heat. The A fibers react to ion effect, C fibers don't. The A fibers react to the electric pulp test, while the C fibers don't. The localization of the pain when the A fibers get triggered is very good, while when the C fibers get excited, it becomes difficult for the patient to locate the pain. Which means, in the opposite direction, that if we deal with pulpitis-like pain and the patient cannot locate the pain exactly, he cannot tell you if it's in the upper or in the lower, and the pain is irradiating to the ear, then we might start to think about C fibers getting excited, which means that this is a consequence of deeper pulpal pathology and more chance to be an irreversible pulpitis than a reversible pulpitis. Same is true for the as far as referred pain is concerned. We don't have referred pain when A fibers are triggered and responding, and we have a lot of referred pain when the C fibers are stimulated. The threshold for the A fibers is low and for the C fibers is high. Another important aspect is in conditions of hypoxia, like developing necrosis. We don't have any response of A fibers anymore, while the C fibers might continue to fire. So once again, when C fibers are firing, it is very often a sign of very end-stage pulpitis, very close to necrosis, and even in some conditions of necrosis with no irrigation, blood flow in the pulp anymore, C fibers can still be firing. The A fibers won't react with an increase in pulp pressure, while the C fibers will. The A fibers will not react to inflammatory mediators, while the C fibers will. And the A fibers will react with hyperosmotic solutions, while the C fibers won't. So, as a result, as a summary, we may say that the A fibers will produce sharp, immediate response that is easy to locate, and it's very often when these fibers fire, it is a consequence of quite superficial damage. A typical example is pain due to cervical erosion or attraction. When C fibers react, or when we have patterns that make us think about C fibers being involved, then most of the time it is about deeper and more end stages of pulpitis, and way more towards the irreversible pulpitis than with the A fibers firing. One of the most important questions that we might want to address is whether there would be a link, whether we could link some clinical symptoms to the pulpal histology. So, why would this question be so important? Well, because we know that there is a very precise transition point from in between reversible towards irreversible pulpitis. So pulpitis starts to be irreversible from the very precise moment that we have bacterial colonization in the pulp with focus of necrosis, even if it is a very limited extension. From a histological point of view, this is the point of no return, is the point of the transition between the reversible and the irreversible pulpitis. It means that we will at least need to take some pulp tissue away. So one of the most important questions is what kind of clinical markers, clinical signs and symptoms might be a clear indication for reversible versus irreversible pulpitis. So we know that in about 40 to 60% of the cases, this process of necrosis can happen in the total absence of any symptom. which makes it very difficult from time to time to decide whether we do treatment or not. And in the past, a lot of people have tried to correlate clinical findings with complicated histopathology classifications of pulp disease, but it's always been of very limited success. One of the conclusions of this publication of 1997 was that it is absolutely hazardous to establish a histopathological diagnosis by clinical means. Those signs and symptoms will always give a valid lead for choosing the appropriate treatment. And this is another trial by Seltzer and I.B. Bender in 1975, and they were talking about different histological states of the pulp, and they linked it to potentially treatable or non-treatable categories. But it wasn't very helpful. So this is the chart from their publication. It wasn't very helpful by any means. So their conclusion was that the diagnosis is considered, and I quote, a prediction based on clinical judgment, or at the best an educated guess as to whether or not the pulp can be treated and saved. So we will come back to this very important question later in the presentation. Let's first talk about the diagnostic protocol. I strongly believe that it is very important that during the diagnostic procedure we follow a strict protocol and we strictly follow the same chronology in any single case. So the first thing to do in this protocol is to have a medical and a dental history. Then we will go to the chief complaint. The first question ever, the most important question ever, is what brings you here? What is the reason of you visiting us? And the third will be we question the patient and we let him talk about his symptoms. It means that in the beginning of this protocol, it's about listening to patients, which is very often apparently very difficult for doctors and dentists in particular. So after we've been taking the medical and the dental history, we jump to the chief complaint, and this is really a very important step in the diagnostic protocol. And this is a nice example which shows how important it is for the patient that we first treat and cure, and we first address his chief complaint. So this patient was referred for a revision of the treatment of tooth 37, and on the x-rays we can clearly see a radiolucent area under the distal root, and the tooth was extremely sensitive to, extremely painful to percussion. So we jumped on the treatment and we removed the aperture and we put some calcium hydroxide in, and we closed everything with a temporary filling. During treatment we got a lot of pus coming out of the distal root, so we were quite convinced that this was the very reason of this was the chief complaint of the patient, and we were convinced that we had been addressing the chief complaint of the patient. But next day the patient called back, and she was quite upset because she was still experiencing exactly the same kind of pain. So she came back, and we realized that she was suffering from pulpitis on the first molar. So if we would have been testing the teeth in a more systematic way during the first visits, we would probably have noticed that this the chief complaint was situated at the first molar and not in the second molar. So while we did something important and useful, it was not a bad treatment, but she was upset, the patient was upset because we did not address the chief complaint. We got in trouble also with the referring dentist because this was a quite recent crown, and we can see some decay underneath the margin of the crown. And we, without even telling the patient was quite upset that we needed to go through the crown, but we didn't tell the patient that it was a leaking restoration, but we had to tell it to the dentist, and she was quite upset, and she stopped referring us patients, by the way. In the end, we did the definitive obturation of the second molar, and we have some MTA here in the distal canal, which explains the radiolucent area in between the root canal obturation and the coronal filling, the provisional temporary filling. So it's important that we address, first of all, the chief complaint of the patient. When it comes to symptoms and pain history, we need to help the patient to make his symptoms clear. So we will ask questions, and we will take the time, and most of the time, only based on what the patient is going to tell, we will know the pathology he's suffering from. So we can ask him questions about when did it start and how long did it last, and what is the frequency. Do you have pain every day or every night? Well, knowing that if there is disturbance of sleep, then most of the time we deal with inflamed pulp. What is the location? What is the course of the pain? Have you got recent dental treatment? What are the characteristics of the pain? Is the pain spontaneous? Is it throbbing? Is it very sharp visceral neural pain, which is most of the time pulpal pain? Or is it rather ligamentary pain, joint pain like PDL pain, which is more dull, it's more musculoskeletal pain? So when we help the patient to make these symptoms, these characteristics clear, most of the time we will know what he's suffering from, even without having to look in his mouth. We might ask him if there is anything that he can do to relieve the pain, what kind of painkillers, anti-inflammatory drugs, very cold water. We will ask him what is going to make the pain worse, biting, cold, hot drinks, etc., etc. And it's only now, after having spent quite a lot of time to talk and mainly to listen to the patient, that we will try to gather objective information about what is going wrong. And in this, during this part of the diagnostic protocol, we will start at a very broad perspective, and then we will concentrate and come closer and closer and closer to the culprit, to the tooth that is giving pain. So we start with an extraoral exam, and then we will do an intraoral exam. And during the intraoral exam, we will first have a general look in the mouth, and then we will get closer and closer and closer to the culprit, to the reason of the pain. And only close to the end, we will take radiographs, trying most of the time to confirm our guess, our educated guess. So as an extraoral exam, we look at the patient and we look at his face, and we are looking for a symmetry. We look to the eyes of the patient. We can do some palpation of some areas for lymph nodes, the size, the mobility, the tenderness. And very important, we will always check the muscles and TMG. I think that on the average I have at least one patient every 2 weeks referred for papaitis, which appears to suffer from articulation or muscle problems. So it's important. Okay, after the extraoral examination, we go to the intraoral examination, and we observe, we have a look at the existing restorations, we look for discolored teeth, parafunctions, presence of disease, and oral hygiene. We look for sinus tract, we do some palpation, percussion, we check the mobility, we do periodontal probing, we can do the cold, heat, and the electric pulp tester. We can make a test cavity, which is a thing I never did, and I will probably never do it. I have emotional problems with drilling cavities in teeth, but that's only me. We can think about doing selective anesthesia. We can do some transillumination, and we can use the frag finder or the tooth sleuth, which I use quite often, systematically. So do we always need to do the whole list? Because this is quite time consuming. In cases of patients seeking help because of pain or discomfort, it's quite easy, because they will tell you, for instance, that they experience pain with colds. So it's easy that we do the cold test, because we need to try to mimic or to reproduce the chief complaint of the patient. And in case of any doubt, we won't treat at all, because we know that a few days later the pathology will spread to the periradicular tissues, and it will become a lot clearer. Instead of doing trial and error and doing some unnecessary root canal treatment, it's better if we, as long as we cannot mimic or reproduce the chief complaint of the patient, it's better not to treat at all and to wait. So in cases of provoked pain, patients complaining about, let's say, sensitivity to hot, then we do the hot temperature test. It's easy. It's quite limited. It's getting more difficult and complicated when patients are complaining about spontaneous pain, and then we need to do a lot more testing most of the time. And it's even getting a lot more difficult when it's about follow-up of treatment. Let's say after trauma or vital pulp therapy, and we want to follow up, and we want to screen if the pulp is staying vital. It might be very difficult because after trauma, for instance, on lots of occasions, electric pulp tests will give negative results, while pulps are most of the time might be vital most of the time. So since none of my patients ever came in complaining about having pain when he's putting these battery cables on his teeth, I hardly use any electric pulp tests in general. As far as the cold test is concerned, we might think about using ice sticks, and if a patient is complaining about sensitivity to cold, ice sticks are more than good enough. In cases of spontaneous pain, we need to go to colder solutions. So we could use the endo ice, which is minus 30 degrees. We could go even a lot colder and go to endo frost, which is minus 50. And we could eventually go to the carbon oxide gas, which is at minus 70. What works the best is to isolate, particularly with the heat test, is to isolate tooth by tooth and spill some cold or warm water over the tooth. And this is the most precise. Based on my experience, patients suffering from deep, dull pain, which might be difficult to localize, very often end stages of pulpitis underneath crown and bridge work. This works really well. You isolate the bridge abutment or the crowned tooth with rubber dam, and then you spill hot water let's say, temperature of warm coffee or tea on it. And then very often, after a while, the patient will start to feel the pain, and the pain will linger for a very long time, and you will be able to find the culprit very easily this way. So as far as the cold test is concerned, we have to be careful, because most of the time patient knows what we are doing. So when we would immediately do the cold test on the culprit, or very close to the culprit, or in the area where he feels pain, there is a risk of anticipation. The patient, being afraid of having pain, will very often anticipate and complain about sensitivity, even if you do not touch the tooth. So best thing to do is to test teeth on the other side of the mouth, to establish a kind of a 0 point, to check if this patient has on the average quite sensitive, cold sensitive teeth, or quite non-sensitive teeth. As we all know, some patients hardly feel any sensitivity to cold in older teeth, and other patients will experience a lot of pain even in teeth with healthy pulp. So it's important that we establish a basis, a 0 point, and then we come closer and closer to the area